Is this working? It's my pleasure now to introduce Wendy Jean Singh, nurse consultant at Hammersmith Hospital in London, to hear the nurse's perspective on the guidelines.
Thank you, Pisana, and thank you for the kind invitation to represent the views of the guidelines from the nurses. It's quite interesting to see that the UK is considered that we have an ideal setup with our specialist centres, but I can reassure you it's not perfect. But I will just say before I start that one of the ways that we've got around having a very small number of referral centres is that we run outreach clinics. So once a month we go and visit patients in geographical locations, normally several hundred miles away from London, and we have run clinics there with the local physicians. And that's quite good for patients because they don't have to travel for so long. It means we have to get up at 5 o'clock in the morning. But it also means that the local physicians learn about pulmonary hypertension. And as Pisana was saying, that when patients then have these minor problems, they can go to their local hospitals who have some expertise in pulmonary hypertension. So back to the guidelines. I'd like to say thank you for including nurses more in these guidelines. When I actually looked, and you do a search for the word nursing in the last guidelines, we only came up twice, whereas in this guidelines, we're here 4 times, so we've doubled in recognition. So, of course, nurses, as we've heard, are recommended as part of the multidisciplinary team, but also part of the team that introduce pulmonary arterial hypertension therapies. And managing specialist therapies, especially the prostanoids, is a large proportion of the work that we do with patient education and helping them manage side effects. But when you look at the guidelines, and it gives quite clear guidelines about the facilities and skills that are required for expert centres, there are quite definite recommendations for the types of medical consultants that should be there and for radiologists and cardiologists, but the clinical nurse specialist role isn't very well defined at all, so I thought I'd add a little bit to it in this presentation. So when you look at the role of a clinical nurse specialist, there are normally 5 main competency areas for the nurses. You're supposed to have clinical expertise, lots of experience in managing patients like pulmonary hypertension. To add to research, to be a leader, to work in collaboration, not just with your colleagues in your specialist centres, but with all of the other centres and the multidisciplinary teams in the centres that are closer to the patients as well, and especially the family doctors. And to work very much as a change agent, to try and help improve things for the patients and their families and for the management of pulmonary hypertension. And a lot of our job is listening and counselling for the patients, supporting them through their illness, supporting them to actually understand what the disease is about. Some of it is direct nursing care, but that tends to become less as the years go on. And I said very much this advocating for the additional resources. We also lobby through our Patients Association in government. And of course, I would say that every team needs to have a clinical nurse specialist because I'm completely biased. But when you actually look at research, when you've added in nurse specialists to other teams of patients with chronic illness, you can see that they've improved the quality of life for patients. The hospitalisations are shorter and fewer because many of the problems can be managed proactively. It actually decreased costs of care, and our government particularly are quite keen on that. And generally just increased patient and health provider satisfaction. And in the years that I've looked after patients with pulmonary hypertension, there have been dramatic improvements. When we first started, the course of the disease tended to be fairly quick over a period of, a couple of 2 or 3 years if you were lucky. But with the increases in treatment and the improvements in management, it's gone from being a quickly fatal disease to being something that is now a chronic disease that patients live with for many years. And when I first started in this role, it was unusual to find patients who had pulmonary hypertension for more than 10 years, unless they were the small group of calcium channel responders. Whereas now many of our patients have been on oral therapies, IV therapies for more than 10 years, and this has very much changed into a chronic disease management. And so therefore the multidisciplinary teams become even more important in their management. And I'll talk a little bit later on about how we need to change probably the way that we address the whole problem and our management of patients. And very much the early focus was on survival, whereas I think now it's really changed into improving clinical symptoms and improving quality of life. So we spoke a little bit about this, and Simon hadn't seen my slides, so actually didn't realise that I was going to talk about some of the patient engagement and self-management. I said this is so important in a chronic disease because of the limited resources of healthcare. The patients will be their own best advocate at times if they're educated and empowered to be able to do this. So I think we've gone from the passive management of pulmonary hypertension, where the patients perhaps 10, 20 years ago would say, yes, I'll take the tablets that are prescribed me, the doctors. I have 2 red ones in the morning, a blue one at lunchtime, and thank you very much. To now, when patients know what the tablets are, they understand why they're taking them, they understand when to call for help. And certainly the very activated patients, the ones that we've seen in clinic, that we teach how to look for signs of heart failure, that weigh themselves on a regular basis, that can make small adjustments themselves to their diuretics, that sometimes even make adjustments to their prostanoids as well at times, within reason. We don't let them just change all their doses. Sometimes have a much better quality of life. They're very engaged with the team, and that decreases their hospitalisations and can generally improve their psychological and physical health. And certainly when we've got activated patients and they turn up in clinic, they arrive in the morning and they present to you their paperwork that they've carefully kept on the computer of what their blood pressure's like and what their weight's been like and how they've adjusted things, it makes our life a lot easier. Linked into that as well is the decision making, but I'll speak about that in a minute. We've already heard that patients need information to be able to make decisions about their disease. And the survey that was done looking at, I'm trying to remember, a large number of patients, actually found that when patients were satisfied with their received information and found it useful, found it much easier to be able to cope with their disease. So it's really important that we educate patients well. And we all think we're very good at communication. We can spend a long time talking to patients, explaining about the disease, explaining about the tests they're going to have and the drugs and the potential side effects. But actually it's the perceived information that's really important. And when you actually look at it, just over half of the patients said that they had information about the disease, or they could remember patient treatment about the disease. They tend to remember a little more about the medical tests, and some of that is related to having to consent for things like right heart catheter. But less than half of them remember being given information about the treatments. And over half of them say that they don't feel adequately informed about their disease. So although we think we've given all the information to the patients, it needs to be in verbal form, in written form, as DVDs, with links to the patients' associations. And on the PHA Europe website now is My PH Library, which is a very good resource because it has patient information in lots of different languages. So actually you don't need to reinvent it because it's already there. And when you ask the patient specific areas that they want to have more information in, there are things like diagnosis and whether the disease is under control and the side effects of the treatments, because those came as part of the questionnaire they were asked. But then the other part of the questionnaire said, you know, there are other things that you'd like to raise that haven't been included. And patients themselves say they want to talk about future palliative care, obviously the possibility of a cure, but they want their own patient records, their own hospital records. they want to know about things like risks of surgery and forms of exercise. But the most important thing that they wanted was to be able to get unstressed, honest, straightforward information that was just really easy to get, that they didn't have to spend 3 hours trawling on the internet to find something specific to them. And so from this, it's been suggested that this could be the ideal optimal patient journey, the information that needs to be given at various stages. If you gave the patients all the information the very first time they saw you, they'd go away staggering under the weight of the paperwork and actually probably wouldn't read anything. So it needs to be appropriate to the time that they are in their journey. So in the first clinic visits, we normally explain about the mechanisms of the disease. And right from the very first clinic appointment, I draw pictures of people to try and pictures of the heart and the lungs too, so they can understand why they need so many tests to diagnose them and what's actually causing the breathlessness and their swollen ankles. And you see this light sometimes go on in their head and say, well, so that's what's causing all these symptoms, and they're all linked together, and that's why my cardiologist says that the left side of my heart is fine and I don't need to worry, and my respiratory physician says my lung function's okay, but I've still got a problem. We also give them contacts of our centre right from the very beginning. They have our emails, our bleep numbers, our phone numbers, and some of them say that sometimes is the most valuable part, because they go home and they have so many questions they haven't answered or haven't asked. And then at time of diagnosis, they need more specific information on their type of pulmonary hypertension, what the treatment options are, how perhaps to manage the emotional impact. We always put them in contact with the patient associations, and the PHA UK actually produce quite a lot of leaflets, but one of them is about coping with the emotional impact of the diagnosis of pulmonary hypertension. And as well as talking to them, so we always give them written information to take away. And our diagnosis and first appointment tend to sort of be on the same visit, because we'll start them on therapy and see them the next day, and they go home with a patient-held record. In that they can keep all of their clinical letters, and there's information in there about pulmonary hypertension for their local doctors as well. We also try and involve shared decision-making as much as possible. Often the patients will present, if they're a young person with idiopathic disease who's had syncope, and they present in functional class 4. When you have the diagnosis, if you follow the guidelines and so you follow your brain, you'll say they need to be on prostacyclin therapy. But in practice, when you've actually talked to many of the patients, they will often find it too overwhelming at the beginning and will not be keen to start on a continuous intravenous infusion, which they'll be on lifelong at the beginning. And so many of them will opt for dual or oral combination therapy at the beginning. And although in your heart you're saying, actually, I want the most therapy for this patient, it's not just treating the physical signs, it's treating them as a whole, and really we need to respect their decision-making. I will say at subsequent visits we always bring up IV, and many of them, after a few months, will then go on to therapy if it's required. They also need information as the disease progresses, information about support, psychiatry, welfare, benefits, support. We do try and match some of the patients to other patients who are in similar situations, so they can have buddy mentoring, and they can sometimes get that through the patients' associations as well. And then as they're progressing through the disease, a sort of 2 or 3 month period, then we really try to engage them in self-management. Give them some, refer them for things like cardiac or respiratory rehabilitation, so they can actually start exercising more, but really to get them to engage with the healthcare teams and patient associations as well. Now, I think we've seen this slide several times already over the last 2 days, but the ESC have very clear guidelines for treatment goals. And the goals, the overall treatment goal is to achieve a low-risk status. And I too would support this because it gives us lots of very clear information about risk. But although they're clear parameters and they're easy to assess, many of the patients, as we've seen from presentations so far, remain in the intermediate zone or remain across all three zones despite pulmonary hypertension therapy. And there are lots of other factors that can influence these parameters, 6-minute walk and their functional class, as well as just the pulmonary hypertension. And many of these goals are not meaningful for patients. The distance they can walk on a 6-minute walk or functional class that the patients can relate to. But often they won't have, they won't come in and say, oh, my PVR is only 6 today, whereas it was 8 before, because actually that doesn't equate to what they're feeling. So when you ask patients what do they actually want, they really want an accurate diagnosis and the best treatment. Without avoidable delay. And we were talking about before about the patients travelling long distances to centres, and we surveyed the patients in the UK, and they wholeheartedly said that they would much rather travel several hundred miles to come to a specialist centre than to see a non-specialist locally. But they also want information and communication I think is key. Psychological, social and spiritual support and optimal symptom control. And then patients actually think towards the future as well, is that they want help at the end of life, more palliative care, and then support for their carers when they have died, and bereavement support for them. And our Patients Association carried out, this was the last survey, the new one is just about to report. When you actually ask the patients what are the most important factors when they choose their pulmonary hypertension treatment, it isn't survival. Survival comes as the third choice, quite closely behind the others, but still the third choice, because what they really want is overall improvement in quality of life and control of symptoms. And that's not surprising, because the quality of life in patients with pulmonary hypertension is either has some or a major impact for 97% of the patients. So we talked here about goal setting. We talked before about shared decision making as well. Part of our work, and a lot of the nurses in the UK have been trained in coaching skills, is to coach patients to identify their own realistic, meaningful and achievable goals. Sometimes you'll have somebody sitting in clinic and say, well, what can we help you with? What would you really want to do? And I once had a man who was in his mid-80s and said, I really want to cycle long distance up hills. And I said, well, because that's what he'd done when he was a young lad many, many years ago. But he said, that was really what he wanted to do. And at this stage, he was walking with a Zimmer frame and could only just walk across the consulting room. So we actually came to a bit of a compromise in the end, and what he could really do that would make a difference to his life was be able to make his wife a cup of tea in the morning, because at the moment actually he wasn't well enough to do it. So we need to achieve realistic goals and work with the patients. Develop a plan to help them achieve it, so that they can actually assess it as they go on. And then just ongoing assessment and re-evaluation. And sometimes the goals that they set in the early stage can then progress. And although my 80-year-old gentleman is never going to be cycling on a bicycle, he will have improved goals as time goes on. So some of the goals that we have from our patients are very different. So there are people who say, I just want to be able to work and support my family. I don't care about the side effects of therapy. I just want to be well enough to go out there and earn some money. Other people who say, I just want to live to see my granddaughter be born. And in fact, the lady that said this saw her granddaughter be born, went to the christening and actually saw her grow up until she was about 2 or 3 before sadly she died. But at that time she said, give me every therapy you can, because this is my goal. Some patients really want to go swimming with their children, and that becomes difficult when you're offering them intravenous therapy. And so some of them will absolutely refuse, because swimming for them is really important. And although I know people have got ways around it, we still don't recommend that people swim with IV. And other patients just say, I want to be pain-free. So if you're considering subcutaneous therapy, that may not be the best for this patient. So as we've already seen, the guidelines speak about psychosocial support. And I'll just pick out one of the elements of psychosocial support. Is depression is significant in our patient group. It's major in about 15% of the patients, and only half of them actually receive treatment. And for about 40% of the patients have mild to moderate depression. And out of those, 70% of patients are not treated at all. And I think it's really important to assess for depression and treat it, because a depressed patient is likely to be less compliant with their medication. They forget to take their tablets, they don't really care about it, they might forget to take their warfarin in the evening, but it doesn't matter because they'll take it the next day. Depression has a huge impact on their compliance with medication. But physiologically as well, surveys have actually shown, or studies have shown, that you get increased levels of IL-6, CRP, you get more endothelial dysfunction, and increased BNP levels. So it's actually having an effect on the physical as well as the psychological health. And we know that depressed people walk less distance on a 6-minute walk, and they have decreased life expectancy. And patients that come into a chronic illness who already have some depression live much shorter times than patients who are not depressed. So I think depression does need to be addressed. And then moving on as well, we mentioned earlier about end of life and ethical issues of pulmonary hypertension, because it is a progressive disease, and there is a call for open and sensitive communication with the patients to be able to allow this advanced care planning. And I would argue that palliative care in pulmonary hypertension needs to actually be started much earlier. Many of the patients that we treat have a significant symptom burden despite optimal therapy. And whether that's a symptom burden from pulmonary hypertension, such as breathlessness and fatigue, or whether it's the side effects of the medications that we give them, it still needs addressing. And it can be used in parallel with quite aggressive pulmonary hypertension therapies. And a lot of physicians will perhaps only consider palliative care as patients are very much towards the end of their life. But I've seen it work very well in conjunction with active treatment. So as soon as the patients that you've got in front of you have symptoms that are not being addressed, that are not being managed, that's probably the ideal time to refer to the palliative care teams. And I think we need to get across the idea that palliative care is more supportive care, and it's not just for patients at the end of life. And certainly we've had patients referred onto our palliative care teams who have been quite severely depressed, very pessimistic about the future, and involving them in their local palliative care and perhaps their hospice care as well, their depression has improved, they've become much more optimistic. We had one of our patients who was a prison guard and a very burly, manly man that used to take the prisoners when they were going to court, because nobody would ever want to run away with him or fight with him. And he was, he didn't show any of his emotions. He was proper sort of English man. And he then actually engaged with his local palliative care team. He's written a nice article which will go in our Patients Association newsletter. And he said he didn't realise how much care there was out there, how much support there was, and he realised that he was actually quite an emotional man, but he was actually allowed to show these emotions and discuss them. And he felt a huge amount of support for it. And so the reason that he wrote for the magazines was to encourage everybody to engage with their local palliative care teams. So just in conclusion, our patients need to be encouraged to accumulate the knowledge and the skills and the empowerment so that they can actually live well with pulmonary hypertension. The successive chronic disease interventions for these patients with chronic disease really do need to involve a coordinated multidisciplinary care team. And my little bid for clinical nurse specialists is that we can provide high quality and cost-effective care to patients through education, support, advocacy, and coordination of care. And I know that there are still some pulmonary hypertension centres in Europe and around the world that don't have nurses, and I would very much encourage them to say perhaps your life might be made a little bit easier if you have got them. And this is to say thank you. This is our UK Nurse and Pharmacist Forum, and this is a meeting actually on Monday and Tuesday this week. We meet up every 6 months, and we try to collaborate to perhaps improve quality of life for our patients and work on the advocacy as well. Thank you.
Thank you very much for this interesting presentation. May I ask you to start the discussion to cover two important questions.